Good morning, everyone, and welcome to Promoting the Use of Health Information Exchange in Action to Address Hypertension. If this is not the breakout session you're looking for, please message the panelists so we can help get you to the right place. While we wait for people to switch into breakout rooms, we want to hear from you. Let us know in the chat box what organization you're with and where you're from. We're expecting people from all across New York State today. Please make sure you select everyone so we can all see your message. You can also use the chat box to ask questions throughout today's session. We'll get to those during the Q&A portion. You can also raise your hand if you want to come off mute to ask a question. We may ask you to raise your hand later on. You won't come on video, but we will be able to hear you ask or answer a question. Now, please welcome our panel today. We have Rachel Kramer, Vice President, Population and Public Health Services at HealtheConnections, Shannon Vigers, Manager of Data Quality and Analytics at Hixny, Tessia Bikelia, Product Coordinator at Hixny, and Ian Brissett, Director, Bureau of Chronic Disease Evaluation and Research at New York State Department of Health.
Great. Can everyone see my slides okay?
Yes, we can.
Great, thanks. And good morning. Welcome to our session. Hope the breakouts and plenary went well for everyone. I'm really thrilled to be presenting on our work and thank AHA for this opportunity. So the title of our presentation is Promoting the Use of Health Information Exchange in Action to Address Hypertension. We're looking this morning to present some data-focused tools that we've developed and really get some feedback from you on our work. So during my portion of the presentation, I'm going to review some of the CDC recommendations for state and public health action to address hypertension. Then we'll kind of level set a bit and provide some basic information about the health information exchange infrastructure here in New York State. I'm going to describe some of the progress that our state health department has made implementing an innovative grant from CDC. And then most importantly, I'll turn it over to my colleagues from Hixny and HealtheConnections to demonstrate some of our work. Before we get started though, we did want to take a poll and just find out some information about who's on this morning and what institutions you represent. So if you wouldn't mind taking a minute or so just to answer our poll, just so that we have a sense of who's in our audience. Great, wow, really nice mix. I see public health well represented, academic medical center, community-based organization, primary care and family practice. So thanks so much. I would say that this presentation should hit the mark for all of you. So thanks so much for telling us a little bit about yourselves and we'll move forward. So to advance or support the Million Hearts Initiative, the CDC introduced 3 core strategies to public health departments and their partners for addressing hypertension. So the first strategy was around tracking and monitoring clinical measures. The idea was to have measurement to identify patients with hypertension and promote hypertension control. The next strategy was around implementation of team-based care for patients with high blood pressure. And the third strategy was around clinical community linkages. So identifying linkage patients from the clinical setting to a community setting, and in particular to services to support self-management and lifestyle change. Again, so in New York State, for those that aren't familiar, we are fortunate to have the Statewide Health Information Network for New York. Or SHIN-NY. The SHIN-NY was developed to support interoperable health information exchange. The idea was sharing information to support care coordination, improve care delivery, patient outcomes, and reduce costs. And within New York State, the infrastructure is set up regionally, and there are qualified entities. So qualified entities are really the regional health information exchanges. Their role is to enroll participants within the health community to allow for data exchange, and again, support care coordination and sharing of information to support outcomes for patients and better care. So the idea was that these QEs, or regional health information exchanges, really would serve as hubs and pull in information from home health agencies, community hospitals, academic medical centers, nursing homes. So the idea is that the QE's responsibility would be to engage, create these relationships, and then also offer to these partners some core services. Core services being, in this case, all of the QEs, and there are 6 of them in New York State, provide access to patient information through a clinical viewer. They also enable secure messaging. All QEs have the capabilities of delivering notifications or alerts, things like a hospital or ED visit alert, and then also delivery of labs. When we saw and understood this infrastructure, it got us thinking that the QEs really would be in a strong position within a healthcare community to support these goals around implementing core strategies to address hypertension. And we actually, as part of a CDC grant, were awarded funding in 2018 to initiate this work. So our idea was that qualified entities could serve 3 kind of core functions. The first would be measurement and enable self-service reporting. So the thought was that we could calculate key measures of hypertension, both at the clinical and at the community level, to support clinical quality improvement and then also population management. Moving down from there, the idea was that the data, the clinical data and information within the QEs and their technology would enable developing registries, action-based tools and alerts that would identify patients with hypertension or uncontrolled hypertension and push them through appropriate care pathways. And then finally, the idea was that QEs might also support referrals, making that connection from a clinical setting to a community resource and enable bidirectional communication. And so with our CDC grant, we proposed testing out, implementing these core strategies, and then also evaluating them in a rigorous way. So as you'll hear, over the past few years, we've been working with HealtheConnections and Hixny to develop a suite of measures that could be used to support this work. And on the hypertension front, it involved measures of undiagnosed hypertension, hypertension prevalence and control. And you'll also see that we've broadened this to include other factors that would influence cardiovascular disease as well. So diabetes and prediabetes measures, and also statin therapy. We've sort of taken a common approach in working with our partners. So as part of this assessment phase, we've sort of looked at the need for and developed business and technical requirements for these concepts. We've also then built and then pilot tested and refined our tools. And we're really interested in now moving into a phase where we're looking to promote and get feedback on these instruments and tools. So you'll be hearing from partners from HealtheConnections and Hixny today, but we've also been working with other QEs. We've made substantial progress, as you'll see, with Bronx Rio, and we're just moving into working closely with the Rochester Rio and HealthyLink, and also plan to work downstate with HealthX as a partner too. So the work you'll be seeing is from HealtheConnections and Hixny, but if you represent another region in the state, we hope to be working and being able to deliver these types of tools to you soon. And in terms of next steps with our CDC grant, so we're in the process of, our goal is to build at least the measurement capacity across all 6 of the QEs that participate in the SHIN-NY. And then separately, we're looking to promote and get feedback on our tools, both the data and measurement tools and also the decision supports. We're focusing on primary care practices, health plans, and local health partners. But honestly, if you have an interest in this tool, we'd love to work with you and make them available to you. And as part of what we're doing, we're collecting data to understand the use of these tools, barriers, and then hopefully document successes that can enable us to sustain this work. All right, so without further ado, I'm going to turn it over to my colleagues at Hixny that are going to present on some of the work that we've done together. So I will stop my sharing. Thank you very much for the time.
Everyone, can everyone see my screen?
Yes, we can.
Great. So hi again, I'm Tessia Bakelia. I'm a product development coordinator here at Hixny. I'm joined by Shannon Vigers, our manager of data quality and analytics. And today we're here to talk to you about all the tools that Hixny has available to address hypertension. First, I wanted to give you a little information about Hixny. We're an HIE connected to 44 hospitals, which is 100% in our region. Between our hospitals and practices, this makes up about 78% of physicians in our area, which is the blue in the map. We have 6.4 million patient records and 5.3 million consents to view those records. We are connected to the SHIN-NY, which Ian went over in his slides, so I won't go too in depth here, but what this means is that not only do we have data connections in our territory, we're also connected to the SHIN-NY. What this means is we can send data to other regional health organizations and receive data from them, such as information about labs, payers, etc. And this is data we can deliver directly to our participants. We have a few different types of data. It's primarily clinical, which comes directly from physicians and providers. We have administrative information like claims data, which we're working to expand. We collect information about social determinants of health, and we also have a patient portal where patients can self-report data such as blood pressure, A1Cs, height, weight, and we're also looking to expand that. So Hixny has a handful of products that pull from this data that can help providers take action on patients with hypertension, which I'll show you in the coming slides. One of our first tools is our reports. Our Hixny Hypertension Reports are available in the provider portal. We have a few different report types for hypertension. We have hypertension needs blood pressure reading, hypertension blood pressure controlled, hypertension uncontrolled. And for the purposes of this presentation, we're focusing on hypertension that is undiagnosed, those patients who have blood pressure indicating hypertension, but no formal diagnosis yet. So all of our reports for hypertension are structured this way. We have our basic patient demographic information in the first few columns, the category, which is referring to the space they're in within hypertension, which is undiagnosed. And we have the value of their latest blood pressure reading, the date, and the facility where that occurred. And we also include their most recent outpatient encounters. From this report, a provider can click on the patient's name, which is linked, and that will bring them to the patient snapshot to view all the other data that has been contributed to Hixny on that patient. And I'll show you what that looks like on the next screen. All of these reports are downloadable and searchable. So a provider could potentially download this as a spreadsheet and use it as a working list for follow-ups, for example, if they wanted to make sure they got everyone on this list in the office to discuss hypertension more, get that formal diagnosis, and develop a plan from there. So if a provider clicks on the patient name, they'll be brought to the patient snapshot, which is where we have our hypertension quality indicator. So if you aren't too familiar with Hixny's patient snapshot yet, this is the large screen in the background here, where we have our patient demographic information and then different tiles with different types of information that have been contributed to Hixny on that patient, like procedures, conditions, labs, documents, etc. And information about hypertension will appear in our quality indicators tab. So I've expanded it here. So in this case, this is a test patient, but if this is someone who had a blood pressure indicating hypertension but no diagnosis, this would appear as a flag for the provider in our quality indicators slide or tile. And this really works as an alert for the provider if they happen to be in the patient's record or they're exploring more about the patient before an appointment. For example, this is drawing their attention to follow up with the patient about this issue in their appointment. We hear a lot about alert fatigue in our industry, so we wanted a way to present this information as a flag without inundating providers with information, though that is something we can set up for providers if they do want alerts. Another thing I should note is that hypertension indicators appear for anyone with hypertension. So if you have uncontrolled hypertension, that would display here instead. If you were overdue for a blood pressure reading, that would appear in the quality indicator slide. Alternately, if you have controlled blood pressure, that would show here in green to show that it's under control and there's not further work to be done at that time. We also have a patient tracker tool. This is something we developed as part of our work with the Department of Health. And the tool allows users to see the numbers of patients moving across chronic disease states in a specific time frame, including hypertension. So you're able to look over a month period, a 3-month period, and see where people started with hypertension and where they currently are or where they ended up after a certain time frame. So did they move from controlled to uncontrolled? Did they move from uncontrolled to controlled? Did they move from undiagnosed to diagnosed and controlled? And we characterize all those types of movements that I just said as negative, positive, or neutral. And we can display this data at multiple levels. We have facility, multi-facility, county, multi-county, and we can also deliver patient-level details. So this is one of those views. This is an example of what we can pull at the facility level. Again, we can capture all different types of movements within the hypertension space, but today we're just focusing on how patients who are undiagnosed move throughout time. So what you'll do in this report, this is accessible in Power BI. These are ad hoc at the time, so this is something you could request from your account manager. But what we would do on our end is select a facility or multiple facilities and a time frame. I just selected 1 month of data, but you can select multiple months to compare. And in the first column, we have the facility name and the prior bucket, meaning where was the patient a month ago? And the new bucket, meaning where is the patient now? We have our disease category of hypertension, the nature of the movement from the prior bucket to the new bucket, and the number of patients who had that type of movement. So for example, out of 200 patients at this facility who have hypertension, 8 of them were undiagnosed and moved to hypertension uncontrolled. We still classify this as a positive movement because it does mean they got diagnosed, and we're hoping that it means they now have a plan to start working towards getting their blood pressure controlled. We also have movement showing undiagnosed patients moving to hypertensive but blood pressure controlled, which is also a positive movement, meaning they were diagnosed and their blood pressure is now controlled. And in this group, there were 5 people. And finally, we have blood pressure, or I'm sorry, undiagnosed hypertension moving into no bucket. This is something that occurs when patients fall off the measure for different reasons, different comorbidities, aging out, pregnancy. So this is a catch-all for those types of patients. We also include pushes and pulls. And what this is referring to for pushes is this is the number of times that this facility had data pushed to them on this group of hypertension patients. And that's the number of times Hixny was pushing data to them. The pull count is the number of times that providers at this facility pulled information directly from Hixny on those patients. So an example of a pull would be going into the report I just showed you or accessing the patient snapshot that I also just displayed. So we can also show other facilities in this view. If you wanted to multi-select facilities, for example, if you worked at a hospital system that has multiple practices and you wanted to compare how the practices are doing at getting people diagnosed and controlled, that is something you would be able to do from this view. We also have a county view. So again, there's a lot we can do with this for hypertension, but right now I'm displaying patients who moved into undiagnosed hypertension, meaning they had a blood pressure reading indicating it, but they aren't diagnosed. This is the number of people who have arisen in that category over the past month. So we have all of our counties across the bottom. And when you hover over any of the counties, you have a pop-up that is giving you more details about those numbers. So what this is telling us is that in Putnam County, there are 96 patients with hypertension. Out of those 96 patients in the hypertension disease space, 7 of them are now undiagnosed and have joined the hypertension group. Even though they aren't formally diagnosed, they're still in this category. And for Putnam County, that is 7.29% of their hypertension population. So you can compare those percentages across the tops of all of the counties. And there's a lot we can do with this. As I mentioned, we could display the number of people who moved from undiagnosed to diagnosed controlled. We could display the number of people who moved from undiagnosed to diagnosed but uncontrolled. And this is a way to show which counties are really excelling at improving those patient outcomes and which counties might need more resources to help focus their efforts on improving patient outcomes for people with hypertension. So since we're talking about a county view, I wanted to pass this over to Shannon, who can give us more information about our last tool, which is Hixny's Public Health Hypertension Reports.
Great, thank you. So lastly, we wanted to focus on the other branch of great work that we've done in partnership with the Department of Health. So using the same underlying data that Tessia just highlighted, Hixny has built a de-identified population level platform. So on this platform, there's both static and dynamic reporting interfaces for diabetes, hypertension, BMI, and ASCVD. Here, we're focusing on our dynamic reporting interface, but there is also a static. In this interface, a user can choose the filters that they would like to use to populate the stratification and the reporting. So to kind of go along with what Tessia had been focusing on, to focus on undiagnosed hypertension, the filters that we've chosen are patients who've had an encounter but do not have a hypertension diagnosis, but do have their most 2 recent blood pressure tests are coming up as uncontrolled blood pressure. By focusing on these specific filters, we can find our undiagnosed hypertension population. When we go to the next slide, we can see this data stratified by zip code and county. So while this shows all of our zip codes and counties, this is also extremely useful and utilized by our local health departments. So Local health departments can utilize this, and public health departments, to identify month over month the counties or even specific zip codes that may need more resources, or to identify if resources being deployed are having the expected impact that they're looking for. Finally, we can also stratify this data by a few different filters. We have age, sex, ethnicity, and race. All of this data is based on our community data, so all of our different data contributors, and that is how we populate and stratify this de-identified platform.
Great, thank you, Shannon. This is the end of our presentation. I know we're saving questions for the end of the overall presentation, so I just want to say thank you again for the opportunity to display our tools.
Can you see my slides? Okay.
Yes,
Okay, so I am Rachel Kramer, and I'm the Vice President of Population Health and Public Health Services at HealtheConnections. I'm going to be talking about what HealtheConnections is doing to support hypertension through our Health Information Exchange. So we are an HIE that serves a 26 county region that is represented by this grayed out area. The green dots are all of the participants across our region. We have 1,600 organizations representing 4,200 locations across that region, and 600 of the organizations are contributing data to us, representing about 6 million lives. Our services represent the core services that Ian identified, as well as similar services to Hixny. These three ones on the bottom, community referrals, My Data, and MyPopHealth, are the services I'm going to highlight in today's presentation. So we were very fortunate to participate in the CDC Innovative Grant with the State Health Department, working with Ian and Tiana and the others. This was a great opportunity for us to lift up the tools we had already started building and align them with what the state and CDC wanted. So we have several tools that, those three tools I talked about, that are designed to help identify and control hypertension. They align with those three areas of work that Ian identified: population measurement, bidirectional referrals, and registries, quality measures, and alerts. All these tools, as well as everything we have at HealtheConnections, are built to solve problems for our partners, for the providers, for health departments, for CBOs. So we're happy to share it today, hoping we'll get some feedback on how to make these better and help meet your needs. So the first one I want to talk about is MyPopHealth. This is a self-service report that's designed to provide estimates of prevalence at a population level. We have several CVD measures that capture prevalence of hypertension, hypertension control, and undiagnosed hypertension, as well as others. We have filters that allow someone to look at an estimate of prevalence by geography, by county, or by zip code, and demographics by age, gender, and race ethnicity. This tool is designed for public health. So it's designed for the New York State Department of Health to use, as well as our local health departments have access to it. The data are presented in an aggregated, de-identified way. These health departments are not looking at individual patient records within this tool. The action they can take with it is to help focus interventions on high risk areas and monitor trends in prevalence. And the data can also be used for grant applications. So here's a screenshot of some of the screens from the tool. We present the prevalence in a map first, so they can look at it in a county level estimates of prevalence. There's also a zip code view of it. We have a bar chart here at the bottom where they can look at the distribution of that prevalence by undiagnosed, uncontrolled, and controlled hypertension. This view is by county. This box over here is filters that they can select by zip code or county or race, ethnicity, age, and gender categories. The data are also presented in the table where they can look at the actual numerator and denominator and export that into an Excel spreadsheet. The second tool we have is a bi-directional community referrals tool that allows providers to refer patients into community-based services and programs. It's a HIPAA compliant tool that has communication back and forth between the provider and, say, a CBO. So the CBO can let the provider know that the patient actually followed through with the referral and received the intended services. As part of our work under the Innovative Grant, we piloted this with providers in our region and CBOs to try to refer patients into services that are relevant to hypertension, like blood pressure self-monitoring program that's offered by the YMCA, SNAP services at the food bank, the National Diabetes Prevention Program, and chronic disease self-management classes. We have other services on the referral tool, but those are the ones that are most relevant for hypertension. So the audience for this was healthcare providers and CBOs. The actions was really to get patients to services offered outside of the healthcare setting to improve health outcomes. Here's a screenshot of the tool. On this black box on the left here lists all the referrals that are available. We highlighted blood pressure self-management program, which is offered by the Y. The tool will help work through the referral form and filling in all the pieces to it. It then gets sent to the CBO, the Y in this case. And then this box shows how the Y can then communicate back to the provider and say the patient attended the class on January 1st. This communication tool actually ends up looking like text messaging because the provider can then send a message back to the CBO and they can talk back and forth. And then this becomes part of the record for that referral. The third tool is called My Data, and it's a place where we have clinical registries, performance trackers for quality measure, data discovery to sort of create your own little registry, and alerts. So this tool was designed to help providers get a better look at their patient profile, identify gaps, and try to test against quality measures. The clinical registries, unlike a registry that you build in an EHR, they are based on community-wide data. So it gives you a bigger view of the data available for each patient. Our hypertension registry is set up to align with AHA and ACC clinical guidelines and can help some providers help them meet PCMH accreditation. We have filters in here similar to what we have in MyPopHealth, where the hypertension registry can filter out by stage, by undiagnosed versus diagnosed, by the last measurement for BP, and co-occurring disorders like diabetes. It also has filters for geography and demographics. The audience for this tool is healthcare providers, and the actions are really to target the needs of patients. So to follow up with patients who need blood pressure measurements if they're out of date, or those who are undiagnosed or uncontrolled, and also to help refer some patients into community services. Here's a screenshot of our clinical registry for hypertension. We set up a attribution list with the provider. So this is a demo example where there's 536 people in the list, and it's broken down to 174 with diagnosed hypertension, 10 with undiagnosed hypertension, and 352 who are at risk. The user can click on this little box and a pop-up would list the patients that are behind it. So you'd click on that and see the 10 patients who are undiagnosed for hypertension. You could then follow up with those 10 patients, get them in for an appointment or see what's going on with them. We have filters over here on the right that I mentioned that could hone in on sort of priority groups of patients you might want to look at. We also show the stage breakdown in these pie charts. You could click on a slice and see the patients that are behind those. The data are also exportable into an Excel spreadsheet. We did build some alerts off of this registry. So instead of a provider pulling data from the registry, we could push out an alert. They were not popular. The providers really preferred that they go to a registry rather than having data pushed at them about every patient that was undiagnosed or uncontrolled. The last piece that I want to review is a quality measure, our performance tracker tool on My Data. So we have this set up to allow a provider or practice to see how they're doing against standard performance measures. So for instance, hypertension control is a CMS measure. And they can use this tool to see how their practice is doing on hypertension control quality measure. And similar to the registries, they're looking at community-wide data, not just data from their EHR. So they have a bigger view of the information about their patients, and they have timely access to these data. The audience is healthcare providers. The action is to help the practice improve their performance on the measure by following up with patients who are due for blood pressure measurements or those who are not under control or undiagnosed. So here's a screenshot of what that tool looks like. This is for controlling high blood pressure. We once again set up an attribution list with the practice. So in here, it's 467 patients. That's broken down into 294 who are compliant with the measure and 173 who are not. You click on this button and see who those 173 patients are and narrow in to figure out who you want to follow up with to improve your performance. This little gauge shows your overall performance on the measure and where you fit in across the state relative to other practices. And here's an example of the list of patients that you would see. Each of them has a little purple button, which would take you right to the HIE. You could look very in depth about all the information we have about that patient, or you have this nice little green button here, which is a snapshot that looks a little like this and just gives you a sort of better organized view of the key pieces of information that would help you understand the context in which that patient is not meeting the quality measure and sort of gives you more information to follow up with them. And that's it. So we're going to do a couple polls just to end this out and then hopefully get a chance to get some feedback from you on what you think of these tools and how we could make them better. So Christy, do you want to do that next poll? It's about, is your electronic health record able to identify patients with undiagnosed hypertension, yes or no? And is your electronic health record able to, oh no, I just did that one, sorry.
Can everyone see the poll?
Then there's another poll. Are we going to see the result of that one first? So no, only one person responded. Okay, thank you. So then the third question is, is your electronic health record able to calculate rates of hypertension control for your patient panel and identify which patients are out of compliance with hypertension control measures? And no. Okay, great. Thanks so much for that info. That just helps us understand sort of what services you're currently working with. Ian, I'm passing over to you now.
Yeah, no, I think we're gonna look through. I'm not sure if any questions came in through the chat, but we can certainly address those first. And then we've got a couple of leading questions that we have.
We do have a couple questions from the chat. These came from the Hixny presentation. The first one is, do the hypertension reports also include remote patient monitoring hypertension data?
So I believe that's self-reported data. Right now, the reports only have clinical readings.
And the next question in Hixny, are the hypertension reports available to health plans? I see plan information is listed as coming soon.
For the patient tracker tool, we currently have health plan data in there, so we would be able to provide that. The reports as well, I believe, Shannon, right?
So the actual reports, excuse me, sorry. are not available to health plans. The patient snapshot is. So at the patient level, the health plans can see all of the quality measures that a patient is either compliant or not compliant in.
We have one more question from the chat box right now, but please everyone remember, if you'd like to ask any more, you can either put them in the chat box or raise your hand to come off of mute. Our last question from the chat box is also from the Hixny presentation. Does this mean we can get community level reports on hypertension control, for example, for the Bronx, that can be helpful for hospital community health needs assessments?
So if your facility is contributing data to us, we would be able to provide that information.
And
Shannon,
this is
do you
Ian, I
have
can
anything?
add, if it's specific to the downstate region and Bronx, send me an email. We could work with our partners at Bronx Rio. I think the answer is yes. I think one of the use cases we saw for the population level measures was the community needs in assessment that I know a lot of hospitals do with their local health departments. So yes, I think that's we would love to work with you to get access to that data to support that population level lens.
Those are all of our chat box questions if you'd like to continue.
Great. Yeah, I think we had two questions that we'd want to start with to get additional feedback. So the first one really is about seeing all the tools that you were on there. We'd love to hear which of the tools stood out as something that you'd be interested in using. So again, I think if you'd raise your hand, we'll be able to comment on that. So did you like what you see? Is there any tool that you saw that you'd be interested in using?
And any participant is, you can raise your hand. If for some reason the function isn't working, please drop something in the chat box to let us know, but you should, oh, we do have a hand raised. One moment.
Hi, can y'all hear me?
Yes, we
Yes.
can. Thank you.
I'm Eduardo Sanchez. I serve as the principal investigator, fancy title. I'm the lead for the National Hypertension Control Initiative that AHA is involved with. And I got to say, I'm just so excited by what I'm hearing. And what I'm interested in doing is seeing if folks on our team, those who are doing work in the New York State area, can connect with y'all. One of the things we're interested in figuring out, and you're using all of my favorite words, population health, quality improvement. As you know, using UDS as it's set up by health centers, HRSA-sponsored health centers, does not provide timely information. You can't, it's inactionable by the time you've got that data. And we've been trying to figure out what out there, in addition to MAP-BP, in addition to our outpatient registry, might help health centers be able to know what's going on quickly. And also for us, I'll just advertise right now, my goal is to say to HRSA, you got to come up with a better mechanism for blood pressure control improvement and all kinds of chronic disease management improvement. You've got to be able to have data that is available in a timely manner and provide some actionability. So I thank you so much. It's more of a comment. I've got all your contact information, so just keep your eyes and ears open. We're going to be connecting. Thank you.
Can I just say thank you so much for commenting? I feel like very gratified. Let's connect outside this call. The use case that you described for UDS is exactly one that we want to be able to address. We've got community level data that can be provided on a more timely basis. And I just want to resonate and kind of reflect back. I agree with everything you said, and I'm so grateful that you participated in our session. So thank you.
Didn't mean to raise my hand again. I meant to do a thumbs up. So thumbs
Got
up.
it.
Yeah, we will be connecting. And I'm so glad that I took the time to be on this session today. Y'all were all outstanding, and thank you for what you're doing.
Thank you. The other leading question we had is, just in general, was there anything that you think we should improve from the tools that we talked about or got missing? So any kind of constructive or even destructive criticism about what you saw. Is there something that we can do better? We'd love to hear from you on that as well. Right. Anything we can do better? Now's your chance.
We do have a comment in the chat. Would love to have access to the hypertension report from a plan level. It would be supremely helpful to our quality department as we look for ways to consume more blood pressure readings.
All right, well noted.
I would say definitely, we can definitely supply one on request, but it is good to know that it was something that would be useful to your teams in the future.
And with that, we want to make sure that people do have time to head back to the main room and get a break in between. So unless our panelists have any other comments, final comments to make. All right, we are now at 10:47. We'll be back in the main room at 11 a.m. Please use the same link that you used for the beginning of the summit this morning. And thank you everyone for participating.
Thanks so much.
Thank you.
Thank you so much.
Thanks.